This is the pre-recorded extended presentation for my speech talk at the GSM 2021 on causal framework for individualized treatment evaluation using multivariate generalized mixed effect models with longitudinal data. Our work started from asking a precision medicine question. That is, suppose up-to-date patient information is used to make a decision, standing at day t prime, what would happen to the person's important biomarkers and endpoints on a future day t if we put the person on different treatment regimes? That is, we want to account for patient heterogeneity in making sequential and dynamic treatment decisions based on evidence from electronic health records. This is a common causal question asked by clinicians when treating patients while having access to massive observational data. However common as the question is, the answer isn't a simple one. The motivating application here is to look at how the initiation of ventilation affects the dynamic progression of patients' important biomarkers and survival endpoints. The data source for this study was Johns Hopkins COVID-19 PMAP registry. All patients admitted with confirmed COVID infection from March to June 2020 were included. The graph here shows the progression of a lung efficiency measurement over time stratified by endpoints being death in red, discharged in green, and censored in blue. Higher measurement indicates better health condition. This plot here visualizes the progression of the same biomarker over time, stratified by observed transition of interventions such that row 1 is going from hospitalization to oxygenation, row 2 is from oxygenation to ventilation, and row 3 is from hospitalization directly into being put on a ventilator. Columns are stratified by transition time, categorized into days 0 to 2, 3 to 5, 6 to 8, and beyond. We focus on the investigation of ventilation and look at row 2 and 3. The biomarker in general gets better immediately after patients gets put on a ventilator. However, ventilation is an aggressive intervention and long-lasting benefits are not guaranteed. The goal of this motivating application is to understand how mortality and important biomarkers vary as a function of ventilation initiation for individuals. Answering this question can be particularly challenging because, first, most existing literature in causal inference look at average treatment effect among a certain group or a target population, and individual causal effects are generally unidentifiable unless given special context or assumptions. Another aspect of complication here is that clinicians tend to make treatment decisions from unobserved factors such as frailty of a patient, which is unlikely to be captured in electronic health records as a specific measurement. In the presence of such unmeasured confounders, the unobserved potential outcomes are not missing at random. Plus, standard tools such as the G-computation algorithm may lead to biased effect estimates. We assume the existence of unobserved time invariant confounders. To adjust for them in analyzing longitudinal data, a common tool is the unit fixed effects regression model, which we are not going into detail here, and its ability to adjust for unobserved time invariant confounders comes at the expense of dynamic causal relationships between treatment and outcome. To address the aforementioned challenges, we propose a Bayesian framework for quantifying the individual counterfactual benefit of dynamic treatment regimes. The framework relaxes the no unmeasured confounders assumption, and it summarizes the evidence from massive EHRs relevant to clinical decisions of a single patient rather than estimating an average treatment effect. For regime comparison, the causal effect for a specific patient is defined as a functional of three parts: the observed longitudinal history up to the day of decision making, parameters estimated based on population data, and simulated counterfactual trajectories of that individual, starting after the decision-making day while accounting for unobserved time invariant confounders. Next, I will introduce some notations that will be used in the rest of this presentation. For the I patient at day T, let YIT be the continuous biomarkers, such as the lung efficiency score. EIT be the competing risk endpoints, which are death and discharge in our motivating application here. AIT be the indicator of being put on the ventilator for the first time, and V is a vector of baseline covariates. We start with the joint modeling of the treatment and the outcomes, which are the initiation of ventilation, lung efficiency score, mortality, and discharge. The assumed causal relationships among the variables are reflected by the following DAG. The undirected arrows among the B's represents the correlated structure of the random effects. In this model, the random effect B's capture a vector of unobserved time invariant confounders in a flexible manner. That is, B's equal to an arbitrary and unknown function of the unobserved time invariant confounders. The random effects influences all treatment and outcomes regardless of time. We adopt the multivariate generalized mixed model here because it is a powerful tool for analyzing complex data with repeated observations. And repeated measurements makes it possible to at least partially inform individual heterogeneity that arises from unobserved covariates. And it is also a popular way of connecting the progression of different time-varying components in modeling. However, difficulties also comes along when trying to use such approach in answering a causal question. Longitudinal causal estimation should only use up-to-date history information to infer on future counterfactuals, while estimation of patient heterogeneity in mixed models usually uses the entire longitudinal trajectory. We address these difficulties as follows. For model estimation, the method utilizes complete longitudinal histories from other patients' electronic health records and generates posterior samples of the fixed effect parameters and the covariance matrix G that provides population level evidence for decision making. Next, we compute the posterior predictive distribution of individual counterfactual trajectories as in G computation, with some tweaks. In this Bayesian simulation, from the longitudinal history collected up to the decision-making day 2, and the hypothesized treatment regime A bar, information flows into the random effects B's, giving us real-time update of random effect estimation, so we can control for unmeasured time invariant confounders to infer on future counterfactuals. The Bayesian update of outcomes random effects is conditional on the treatment heterogeneity BA for identifiability. Intuitively, this is analogous to conditioning our causal comparison of treatment regimes on some pre-specified unobserved level of frailty, which is a time-invariant patient characteristic that was not captured by the data, but confounds both the treatment and the outcome. On top of the real-time update of random effects, counterfactual trajectories also consist of information passed down from previous observed history based on evidence from other patients' records. That is indicated by the blue arrows. Lastly, causal comparison is accomplished by computing the target quantity as a function of the posterior counterfactual trajectories under different treatment options. An example is to look at contrasts of cumulative hazards, such as the log ratio of cumulative events between two regimes. In the next pages, I am going to show some preliminary results of the method. Here we consider a person who was observed to be vented on day 12, but unfortunately died on day 6, since his or her being diagnosed of COVID positive. We are interested in projecting forward the outcomes progression between day 13 and day 24, comparing two treatment options that are the observed treatment strategy as venting the person on day 12, as shown in the first row, versus never venting the person as shown in the second row. In this plot, the black line is the person's observed lung efficiency score in the electronic health records. The gray spaghettis are posterior samples of counterfactual lung efficiency trajectories. The red and green dots represent simulated death and discharge endpoint of those gray spaghettis, respectively. The higher the lung efficiency score, the better the health condition, hence higher chance of having a discharge. Columns of these plots compare different levels of patient heterogeneity in treatment assignment that are being conditioned on for these counterfactual projections. A lower percentile of the unobserved tendency in obtaining treatment might indicate a person being more frail and that being put on a ventilator is less preferred. The next plot summarizes how the comparison of discharge and death varies by these unrecorded tendency of treatment assignment. For example, for this particular person with higher tendency of being assigned treatment, the benefit of venting on day 12 over no ventilation becomes slightly more pronounced than when the unobserved tendency was low. Thank you. That's all of my talk.